next session, and next session is Stalwarts Speak Glaucoma. So this is session 2, and in this we have Dr. Bibhuti. Dr. Bibhuti is here. Dr. Bibhuti, Dr. Arup is there. Dr. No, he will be convening the session, and Dr. Swati. Dr. Richa said she will come late. Dr. Swati, are you there or not? All right, so I think we will start the session to keep the time, and I think is anyone? So we have our speakers. So we have, I think almost everyone is there except for Dr. Talveer. She couldn't come, so I think we'll have to start with Dr. Kirti Singh. So Dr. Kirti, are you ready with your presentation? So Dr. Kirti is speaking on a very important topic, identifying gaps in glaucoma practice, which I think is very important. So I'll straight away invite Dr. Kirti to present a talk.
So, good afternoon, everybody, and I'm thankful to AIOS for giving me this opportunity. I'll be talking on something which is a little unusual. I'm not talking about any surgical innovation or surgical procedure or a new drug. I'm talking about patient-doctor interface. We are ultimately here to treat patients. We need to know how we fare in glaucoma practice. Are there gaps in our glaucoma practice? Are we still missing the boat? Despite so many CMEs, so many lectures, so many innovations, so much of expertise, are we still missing the boat? Now we know all these statistics. India is home to 20% of the world's blind population. That's a very ignominious statistics. We also know that 70% of blindness is preventable. 6% of blindness in India is glaucoma. So where does that leave us? Let's do a gap analysis, because the best of plans goes haywire unless you do a gap analysis. And for glaucoma practice, the gap is between analysis between the patient and the doctor. We did a data analysis from our Guru Nanak Eye Center on 17,100 patients. They were from mixed ethnicity, and most of them were old, but 6% were even young patients. As expected, primary glaucoma was common at 78%. Both open angle and angle closure were similar, as has been said multiple times. The fact which is highlighted is that almost 1/4 of the patient referred to a tertiary care medical center of North India, when they reached us, either required surgery or laser. 14% were severe presentation, means blind in one eye, PL negative. Of all the blind persons, PACG comprised 46%. ACG prior treatment, only 20% had a prior PI, 80% were undiagnosed, and the PI which was done also was done in our hospital. This is the ignominious statistics which I want to highlight. OAG, only 1/3 were on anti-glaucoma medications, and only 5% had undergone a prior trabeculectomy. We also did another analysis on the knowledge and health-seeking behavior of the glaucoma patients and the referral practices. Of the 500 patients reviewed, 86% were in the 7th decade or older. Majority, because being a government hospital, 43% lacked any formal education and none had any health insurance. Again, POAG and PACG were very similar. 48% had severe visual field defect, legal blindness in 37%. So the previous data was on 15%, now it is 37%, but however, now we have less patients, 500. 85% were residents of Delhi. 75% traveled almost 10 to 30 kilometers just for drug refills. Delay in seeking treatment of 6 months was there in 41%. The reason for this delay was ignorance. We did not know that we have glaucoma and we need early treatment. We thought it is cataract. We thought IOL se theek ho jayega. We thought chashme se theek ho jayega. Lack of caregiver in 22%. No access to nearby health facilities in 36%. Despite a qualified ophthalmic referring physician in 92%, this was the referral practices audit which we did. Only 20% had been able to diagnose glaucoma. So 80% of our fraternity had not diagnosed glaucoma, despite this fact that almost 30% of these patients had had a prior ocular surgery, usually cataract. Despite that, glaucoma was not diagnosed. The criteria for referral to glaucoma clinic was high IOP in 60%, dys suspect in 39%, poor vision 38%, visual field suspect 11%. Gonio suspect referral was abysmally low at 5%. Gonioscopy was neither performed nor documented. So as we say, if it is not documented, it means it's not performed. It was neither performed nor documented in 80% by the primary care ophthalmologist. The gonio done by our residents before referral to our clinic was pretty robust because the referral practices of our residents were synchronous with the glaucoma fellows in 98.54%. So gonioscopy was diagnosed as was analyzed as the biggest gap. This has been corroborated elsewhere by the famous Chennai glaucoma study, where PACG was misdiagnosed and it has POAG in 40%. In the Venkatraman study in Coimbatore, where gonioscopy was missed in 95%, and glaucoma awareness has been poor all over India, has been corroborated by other studies also. Surprisingly, a study from Canada also said that lack of angle status information 74%. And remember, mind you, here everything is audited. So glaucoma awareness for our patients was very poor, and awareness was 9%, knowledge was even less. Only 8% understood the irreversible nature of disease. 5% still felt that IUL would cure everything, and once you put an IUL, it will reverse. What were the perceived? Why was this such poor adherence was there? Because it's an irreversible disease, and the patients, after putting drugs, felt there was no perceived benefit. It was lifelong medication, improper installation technique, as you can see the patient putting on the right side, cost, availability of drug. The disease is very asymptomatic in the early stages. So coupled with the no perceived benefit and asymptomatic, and to add to that, lack of knowledge led to the poor adherence. Please let us remember, this is a disease of the elderly. They have hand-eye coordination, poor manual dexterity. They are forgetful. It is easy to take medications. As you can see from this box, it is easy for you and me or anybody to take the medications Sunday to Saturday every week. But for eye drops, there is no such counter. The last thing was a CAP study on 200 diagnosed adult glaucoma patients on glaucoma medication the last 6 months. Only 39% had an income source, 20% had one eye glaucoma blindness, and poor adherence was there because of fatigue, forgetfulness as the most common cause, buying capacity, side effects. White coat adherence was diagnosed by us in 26% patients. So adherence was not bad in these patients who were on 6 months of at least treatment at 68%, but knowledge about glaucoma was better in this group. Disease misconceptions still ruled at 53%. 68.5% were unaware of the continual asymptomatic nature. 50% understood the gravity of missing medications. 53% again had a false belief कि दवाई डालने से कुछ तो फर्क पड़ेगा. Drug installation practices were extremely unsatisfactory in 57%. Provider factors, namely suboptimal counseling or demonstration how to put the drugs, were identified as a must-show aspect कि हमें किसी ने बताया नहीं कि कैसे डालनी है दवाई. 56% preferred surgery, last slide, and 44% had a dependency on escort. This CAP study previously had also highlighted this instance of medicines available. So what was the gap? Many patients are one-eyed. Many patients rely on free medicines. Patients are forgetful. Patients are dependent on family. We need education that meds halt progression, not reverse disease. You need to link the medication to daily activities. You need to solve the root problem by exercising surgical option frequently. And this counseling is required for these patients. And for this gap analysis, we need to do gonioscopy. And in Guru Nanak Eye Center, we started a gonioscopy and perimetry workshop over the last year, in which we have done. Last but not the least, please remember, we are all surgeons. Trabeculectomy and PI in time can make sure that you do not miss the boat for these patients who come with legal blindness in almost 40%. Thank you.
Thanks a lot, Dr. Kirti, for presenting this gap analysis study. It brought out a lot of facts which were known, but we didn't have the numbers, and some of the facts which are unknown. So, what steps you have in your mind, to bridge this gap in due course of time? And I would also like to get the opinion from Dr. Pandav.
These steps: education of the patients, which we do counseling. Unlike the Arvind group, which has a very robust counseling, most of the government hospitals do not have. It depends on the doctors. So we've trained the nurses to do the counseling for all the patients who come to glaucoma clinics कि दवाई नहीं भूलना है, खाना खाना भूल जाना, दवाई सुबह नाश्ते के साथ खानी है, डालनी है, रात को खान डालनी है, 3 बार डालनी है, कैसे डालनी है, नाक और आँख बंद करनी है लेटने के टाइम. They just have a small video which we show them, and ये दवाई ज़रूर डालनी है. What I do in addition is I identify the caregiver. Most of our patients, as I said, are above 70. Many of them have dementia, many of them do not remember, so I take the name. Let's say, अच्छा शशि आपकी मम्मी है ये, शशि बच्चे आपको ना अपनी माँ की दवाई उनको याद कराना है, and I'll tell the mother also, your daughter Shashi is so good, she's taking care of you, या आपकी बहू है तो बहुत अच्छी है. So I make them feel responsible, or our residents make them feel responsible, identify the caregiver so that the caregiver can take care of the older parents, and counsel the patients how to open the bottle, unscrew it and put it. That videos we do the counseling then. And lifelong medications, what they very often ask me, how long do we put the medication? So our typical answer is, marne ke आधा घंटे बाद तक. So, it's just reinforces, and irreversible, it is very scary for them ki will I become blind? So you have to just tell them that whatever is, we had coined a phrase, जो चला गया उसका गम नहीं, जो बचा हुआ है वो कम नहीं. So, you just give them some solace and explanation that this vision will suffice. Just keep putting the medications. They will not improve your vision, but they will maintain the vision. And the caregiver identification, that's the patient identification, and linking with the medicines to the activities will help them increase the adherence. And many of our patients come from very peripheral areas. Will they never come back to us? Especially ACG is 50%. So we do a combined surgery or a trab pretty early. Not for clear cataract, clear lenses, no, I'm not promoting that. But moment you have a threshold for cataract and trabeculectomy is combined surgery is less in our setup, and threshold for trabeculectomy is also less, because if you have more than 3 medications, they are bound to forget. And we have too many ACG patients, so in that case they become even much more, they progress faster. So we do a surgery early. So these are the, to answer your queries, this is what we are doing.
When actually what I have felt is, we generally tend to emphasize glaucoma awareness and promotion of, knowledge about glaucoma, the World Glaucoma Week. It should be a year-long effort. So in most of the hospitals, what we do, and we tell our colleagues to do, is have a counter, and a counselor sits all the time. There are posters in certain areas of the hospital where the counseling is going on year long. It is not just focused to.
We just have the videos actually. Yeah. Posters, many of our patients can't read it. They are beautiful posters, but they will not be able to read it. So videos we have which keep happening.
I think what Dr. Kirti has highlighted is actually of immense importance. Even if you have, best of the drugs and the state-of-the-art surgeries, but unless patients are aware of it and they will no use to the patient, or they can use it. So I think your gap analysis is absolutely I think need of the day, and
I've been here for the last 25 years,
yes.
One of a decade
so
in my
and
we still have this 25% coming to me with blindness.
Yeah, we need to, that indicates we need to make more efforts, and more of us actually need to do that.
Acronym and perimetry workshop, the gap workshop, which we do at every glaucoma week.
I think for in view of the keeping the time, I think we move on to the next topic. What's the next topic?
So thanks, Dr. Kirti. So we move on to the next topic, and that is also very important by Dr. Manoj Mathur, Treatment Philosophy in Medical Management of Glaucoma.
Thank you, Dr. Arup. Good afternoon, everybody. So, I shall be briefly speaking about the treatment philosophy in the management of glaucoma. What is glaucoma? It is described as a family of ocular diseases characterized by progressive optic neuropathy and visual field loss. So what happens? There is a progressive retinal ganglion cell loss that results in gradual optic disc cupping, and this is associated with visual field deficits. And mind you, elevated intraocular pressure is no longer included in the definition. So what is the treatment philosophy basically? If we consider primary open angle glaucoma, the aim is to prevent nerve fiber loss, to prevent any further visual field deterioration, and most important, to retain the quality of life for the patient. If you see this curve here, as the age advances, or at the top, there is a normal physiological loss. So if you detect the disease at the point in the center, if you leave it untreated, it goes into the realm of blindness. So the aim of treatment is not to skew the curve upwards towards the normal side. You can't regain vision, but you have to treat the patient in order to see that this curve runs parallel to the normal physiological loss. Then visual field deterioration, whatever has happened, you have to maintain the visual field loss to the same extent, and in this case prognosis by recording also the 10-2 visual field. The quality of life is most important. It is hard to quantify, but for the patient it is the most important. The very diagnosis generates anxiety. The functional loss due to the disease, the inconvenience of treatment. For us it is very simple to prescribe this drop 3 times a day, 2 times a day, once at night. But how inconvenient it is if you are prescribed similarly for the rest of your life. The side effects of the treatment, and last but not the least in our situation, the cost of the treatment. So what we can do, can only modify and control IOP. Can we afford some sort of neuroprotection and vasoprotection to the patient is a bonus in the medical management. So whenever you think about management of medical management of glaucoma, you need to refer to this figure, how much range that you need to set, a target range for your patient in order to see that the patient doesn't progress within the normal range. So basically to come to a target range, you need to assess the amount of damage at the time of diagnosis, the life expectancy of the patient, and the IOP, the baseline IOP at which the damage has occurred. And based on these factors, whether the damage is early, you can have set a higher target pressure. If the damage is advanced, you have to treat the patient much more aggressively and bring down the target range to low. Similarly, life expectancy, if the life expectancy is long, you need to reduce the pressure further, and even the IOP damage has occurred at a lower the lower intraocular pressure, you have to bring it down aggressively further down. So can you afford some sort of neuroprotection and vasoprotection? Studies are positive, but still yet to be established. So the treatment goal of glaucoma management is preservation of visual function adequate to individual needs with minimal or no side effects for the expected lifetime of the patient without any disruption of his or her normal activities at a sustainable cost. What all we have discussed in the previous slides boils down to this particular statement issued by the European Glaucoma Society guidelines. This should be the dictum, the guideline for the medical management of glaucoma. Now the next thing, after knowing the definition of management, what is the mechanism of action? Basically, the anti-glaucoma medications, they act at the inflow level by reducing the production of aqueous, and there are outflow facilitators. The outflow facility can be due to the UV scleral outflow as well as the trabecular outflow. So the outflow facilitators basically available for us in glaucoma armamentarium are the prostamides, the alpha-2 agonists, cholinergics, prostaglandins, and recent ROCK inhibitors, whereas the inflow reductors are alpha agonists, beta-1 blockers, carbonic anhydrase inhibitors. So the treatment goals, what do you aim to achieve? How do you assess a particular anti-glaucoma medication? You must assess by these 3 points. The ability to modify, and what is the ability to modify? It is the intraocular pressure, how much effective it is. The second thing is the safety profile, both ocular and systemic. And third thing, does that medication offer you some sort of a protection, a bonus, additional bonus by way of neuroprotection or a vasoperfusion. So the earliest form from the anti-glaucoma medication was pilocarpine. It used to act by opening up the angle and improving the trabecular outflow. Its efficacy was good, but the side effects of this was visual disturbances and brow ache, but it was a cheaper treatment. Then came the beta blockers. They revolutionized the treatment of glaucoma, and then followed by brimonidine. It has a dual action of mechanism. The side effect profile was hyperemia and drowsiness. Then came dorzolamide, brinzolamide, the carbonic anhydrase inhibitors. They have a different mechanism of action. They act at the production of aqueous level only, but since they act by a different mechanism of action, they can be combined with timolol. Then came the prostaglandins, the latanoprost, the travoprost, the bimatoprost, and of late the trafluprost. These four molecules, they act by increasing the UV scleral outflow and by giving some sort of a vasoperfusion, the endurance, and a better diurnal control all through the 24 hours. Then the recent kids on the block, the ripasudil and the netarsudil, they afford some sort of anti-inflammatory properties, and they act by opening up basically the trabecular meshwork, improving the outflow facility through the trabecular meshwork. The importance of combination treatment, as now lesser the number of drops, better for the patient. So if you see all the combination medications that are available in our armamentarium, all the medications up till now were combined with only timolol, but the introduction of brinzolamide brimonidine combination opened a Pandora's box, and it has led to such a situation that you can combine even 4 molecules in just 3 drops a day in 2 bottles. This is not a mathematical model. Every patient is different. How one patient reacts to this, every patient need not react to that. You have to select the best combination for your patient and manage your patient accordingly. So the clinical guidelines in medication always start with a first choice monotherapy. If the target pressure is reached, continue, IOP is maintained. Periodically verify the endpoints, that is, as I have said, the quality of life, the visual field, the optic disc, and the IOP. If the target pressure has not reached, the medicine is acting, but the target pressure is not reached, in such a situation, you need to add a drug. But if you have not the target pressure is not reached, the medicine is not acting, in such a situation, you need to switch the drug. So thank you very much for your patient hearing.
Do we have time for
If there's any quick questions from the audience. I think Dr. Mathur has actually covered very comprehensively the basic fundamentals of drug therapy without going into all the details, nitty-gritties, because they can't be discussed in 7-8 minutes. But I think there's a wonderful job done. Thank you very much. And if there are any questions, we might have still time at the end. I think we'll take them up at that time. So we can. I think we'll go on. I think I'll request the next speaker, Dr. Sanjay Kumar Daulat. He will be speaking on pearls and pitfalls of interpretation of OCT in diagnosis of glaucoma.
Excuse me.
We are following the same order.
Good evening. I'll be speaking on pearls and pitfalls in interpretation of OCT and diagnosis of glaucoma. There are 4 different manufacturers of spectral domain OCT, and we examine 3 different parameters for diagnosis of glaucoma. We have to remember each machine has different scan patterns and different software, so we cannot compare the data of one machine with another. First of all, we must check the patient's name and age, because all data is compared with age matched normative database and color coded accordingly. Then we must check the signal strength, because there is a minimum acceptable quality level for each machine. For example, Cirrus, it should be more than 6. For Topcon, it is more than 45. Lower signal strengths give lower RNFL thickness. So a drop of lubricant not only improves the signal strength but also RNFL thickness. It has been reported that there's a 9% increase in average RNFL thickness after cataract surgery also. Next, we must know the color codes. This is important because the values more than 95% are labeled as white, and the values that are not compared with the normative database are shaded grey. So not only red and green, we should also know white and grey besides red and green. In our over enthusiasm for embracing OCT in the diagnosis of glaucoma these days, we have come to a point that sometimes we rely solely on the colors for the diagnosis, and this should not be the case, and this has led to the terms called red disease and green disease. Every technology has its own limitations. Sometimes the blood vessels cause shadowing on segmentation, giving lower RNFL values. Sometimes we used to see in the past motion artifacts characterized by horizontal displacement of images, but nowadays this is not common because of faster acquisition of images. Sometimes a floater comes in the path of calculation circle, giving us lower RNFL values, and this changed to normal after blinking when the floater moves away from the calculation circle. So broadly, all the artifacts in imaging can be divided into three groups: the patient dependent like media opacities or dry eye, operator dependent like signal strength or scan alignment, or device dependent like normative database. So this Heidelberg printout shows red colors on sector analysis, and when we see the fundus, we see the toxoplasmosis is the cause of RNFL thinning. So this is not glaucoma. This is a Cirrus printout showing lot of red areas in sector and clock hour analysis and RNFL thinning on RNFL deviation map. But when we check the fundus, we see that these are myopia. And in myopia, the superiotemporal and the inferotemporal bundles converge temporally. So the height or the RNFL thickness is normal, but it is displaced laterally. So in the expected areas, they appear to be thinned out. So this is myopia and this is not glaucoma. This is Cirrus printout showing red areas in the RNFL table. So when we see carefully, the disc has not been centered properly. So when we center the disc, all the colors change to green. So this is a centration error by the operator. Another printout from Heidelberg showing red areas in the sector analysis and RNFL thickness in the TSNIT graph dipping into the red zone. But if we observe carefully, we see that the RNFL tomogram has not been centered properly. And once this is centered, the values change to green. So this is again a centration error. I'll be giving a couple of examples because of the constraints of time. So this next example is from Heidelberg showing a lot of red areas and the RNFL thickness dipping to 0, which is not practically possible because of the presence of glial tissue and blood vessels. And this occurs usually in tilted disc and posterior staphyloma in myopia. So this is a device dependent segmentation error. There's another device dependent error, and that is normative database. Each machine has its limited normative database. For example, Cirrus has a normative database of 284 individuals only in the age group 18 to 84 years, and refractive error -12 to +8 diopters. So due to this small normative database, many results may be flagged abnormal statistically, because these patients are not represented in the database, but they do not represent the real disease. So we should be alert about these facts and not overtreat this red disease. The vice versa is also true. Sometimes there may be a patient of glaucoma, but that may be masked by the green color. So this patient has glaucoma in both the eyes, but the OCT has picked up glaucoma only in the left eye. And when we see the fundus, we see that there is a myelinated nerve fiber which has caused the masking of the RNFL thinning. And in fact, this is in white, more than 95% of the thickness in the OCT. So we should be careful about the other end of the spectrum also. Another important point to remember in OCT is that the RNFL thickness cannot go below 40 to 50 microns because of the presence of glial tissue and blood vessels. So in advanced disease of glaucoma, we must rely on automated perimetry and not on OCT. To summarize, OCT alone should not be used to make the diagnosis. An abnormality in the OCT requires clinical correlation, and this is not man versus machine, but man plus machine. Thank you AI Scientific Committee, especially Dr. Partha Vishwas and Dr. Amit for giving me this opportunity, and Happy New Year to all.
Yeah, thank you, Dr. Thakur. I think you covered the topic very well, because this is very important to understand where you can go wrong in OCT, in the interpretation of diagnosis of glaucoma particularly. And I think you have done some very good examples, very clear-cut examples where things can go wrong. I think there's a wonderful lecture. Any questions to Dr. Thakur? Okay, thank you very much. I think we'll go to the next talk. The next talk is Abhishek Onkar, and he's talking on drain to sustain glaucoma drainage devices for interactive glaucoma. Abhishek, is he there? Dr. Pranav Ranjan. Dr. Pranav is there? Yes. Dr. Ranjan is speaking on artificial intelligence in glaucoma.
Good afternoon, all of you, and welcome to the first midterm conference on behalf of local organizing committee. This is a very interesting topic, and even I am in the phase of learning this topic and trying to understand as what artificial intelligence can do in the diagnosis of glaucoma. So primary open-angle glaucoma is the most common subset of glaucoma, with 53 million cases worldwide. And we do not have strategies as to really diagnose accurately whether it is a glaucoma or a non-glaucoma case, especially in the early cases. Tools that are disposal are shown in the picture. These are used for making a diagnosis of glaucoma. So optic nerve is like a telephone connection between the eye and the brain. They see in the picture here, a diagrammatic representation. Artificial intelligence is being used primarily in diabetic retinopathy, glaucoma, age-related macular degeneration, and IOL power calculation, apart from other eye diseases as well. Why this is important is because early glaucoma is typically asymptomatic, and like for example, detection depends on clinical examination. For example, patients of macular degeneration, they can present early, whereas early glaucoma patients do not present early. They present only when the disease has progressed to a fairly larger extent. And progression can be subtle and can be difficult to appreciate in the initial stages. The reality in Indian scenario, rather global scenario, is that with more patient time and less chair time, one needs a high priority checklist to ensure nothing important is overlooked. With approximately around 90% rural and 50% urban population remaining undiagnosed, there is a need for a robust and a fast, accurate screening methodology, and artificial intelligence as such fits the role here. Role of artificial intelligence is in screening, early detection, diagnosis, classification of glaucoma, quantifying risk factors, and progression. And this is done by automated processing of large pool of data, which can be done by artificial intelligence. And why we have picked up a glaucoma for artificial intelligence is because of the fact that glaucoma is a mystery disease. Many of the variables in glaucoma do not have a definite cutoff line, like the intraocular pressure of the optic nerve changes, the RNFL, the ganglion cell layer, etc., etc. Family history and systemic diseases also influence glaucoma, so diagnosis requires to incorporate all the borderline cases to start early treatment and predict a course of the disease. So all these have to be integrated to come to a final conclusion. Some of the basic definitions of that we come across in artificial intelligence is that uh, what is an artificial intelligence? It is a science of applying computer algorithms to replicate intelligent human behavior. We have machine learning, is the capacity of the computer to learn from experience, to modify its processing based on newly acquired information on its own. Neural network, a software is built as a network of neurons communicating with each other with multiple inputs, modifying the output with a feedback loop of learning. And deep learning is a class of machine learning algorithms that uses multiple layers to progressively extract higher level of features from the raw input. For example, an image processing, the lower level layers may identify the edges, while the higher levels may identify the concept relevant to humans, such as digits or letters or the elevation of the faces. So it is a kind of advanced level of neural network. Coming to the basic factors which we take into consideration for glaucoma diagnosis, the intraocular pressure, the IOP trends from previous data and medication are useful for artificial intelligence. In one study, artificial intelligence was used to evaluate a large pool of data using a seismoid triggerfish. And Martin et al. Used this data from 24 prospective studies of triggerfish using random forest modeling, a machine learning method to identify the parameters associated with glaucoma patients. Why this was relevant is that when we see the office intraocular pressure reading fluctuation and the 24-hour fluctuation, we find that with the office time intraocular pressure fluctuation, we see the blue line, which is marginally, not only marginally, but substantially lower than what fluctuation we get in the 24-hour period. So with this, what can be done with the artificial intelligence is that we can pick up 2 points, and with large pool of data that can be compared, and then we can really find out what kind of fluctuation the eye can have in 24 hours time. Optic disc photograph is another important factor, and there are and a lot of studies have evaluated that it has got a high sensitivity and approximately 95.6% and specificity of 92% for glaucoma detection. There are various studies that have been done, and how that is done is that a large pool of data, a fundus photograph, they are labeled as glaucoma and non-glaucoma by experts, develop a computer algorithm and which can be better than the actual human examination. The picture is shown here in the bottom, how this is done. So what the eyes see basically is an image, is a picture in a color picture. Whereas what does the fundus imaging of the computer does? It breaks it down, segments it into numericals and pixels. And these large number of pixels, they are accumulated with a large pool of data, and whenever a new patient comes and the fundus photograph is captured, they are also converted into numericals, and these numericals are compared with the normative data or the disease data, and as per that, a result is given for a final analysis. So there are a few examples like Calf Innovations released retinal image analysis, glaucoma cloud-based software in 2016 to analyze the fundus images. Can you just one? Okay. Coming to the OCT and OCT findings, the OCT automatically measures the disc size, cupping, neuroretinal rim area, and RNFL thickness and the GSL thickness by using artificial intelligence, the image processing techniques known as segmentation. Mohammed et al. Has shown that a hybrid deep learning method on a single wide field swept source OCT has 93% sensitivity in detecting glaucoma suspects. Ashoka et al. Has evaluated a deep learning algorithm with a pre-training that diagnosed glaucoma based on macular OCT for RNFL, and GCL. Likewise, for anterior segment also, we have algorithms which can analyze and depict whether the patient has got the kind of angle closure the patient can have. Visual field, a lot of research has been put into visual fields. Uh, it has a rapid and an accurate interpretation. There are a lot of studies which have been done. And I'll just go into one of the most important which I found is that the fields do not quantify the nature of regional field loss, and summary indices is limited to overview only. So we need a more information on early detection and management of glaucoma. And this archetype analysis was developed by Tobias Elias from Harvard. He provides an objective and quantitative information on the regional field loss. And what he found was a 14 type of field patterns that was seen in 2045 eyes, studied over a period of 25 years. And what he found, the most interesting that he found was in this field which had an early central field loss. And this is characterized, and this kind of a field loss was characterized by a rapid progression. So these kind of feedback from the previous studies put into artificial intelligence can really be helpful in aggressive treatment and management of glaucoma patients. Predicting prognosis is also important, and Yosef et al. Showed that the machine learning detects visual field progression consistently with slow progressors. It works on portable perimetry devices, and all these can be helpful guide for customized target intraocular pressure. So future prospects, algorithms are always getting better. We expect in future to have an artificial intelligence with an extremely good sensitivity and specificity to surpass human ophthalmologists. Combining various glaucoma evaluation can achieve a near perfect diagnosis and prognosis. What is desirable is a single test that can extrapolate and predict the other using artificial intelligence. For example, an OCT predicting visual field by extrapolation. So these are the 6 pearls which we have to keep in understand. Yeah. And the future incorporation of artificial intelligence into healthcare models may help address the current limitation of access of timely management of patients with glaucoma all across the world. Thank you so much for your kind
Thank you, Dr. Pranav. I think you have given us details of where the AI can help in glaucoma diagnosis and management. I think this is a very emerging field and still not very well understood by most of us. But in future, I think this is going to play more and more role, especially when you have enough data, because AI is data driven basically, and so once we have more and more data with us, digitized data, probably we'll get better at it also. The computers will become better at it, and we'll also become better at it, what the computers are telling it. But I think there's a bit of mystery in AI as far as we are concerned, the way we understand it. But it is going to definitely, AI is going to play
what
a
I think
role.
is the best part of it is that if you have a software in which you can put in just 4 or 5 data and which can really predict, I mean, that can give a clinician a high level of suspicion that whether the patient has a glaucoma or not. So that is one of the
I think
the
that's
best
one of the ways
you cannot
that,
100% depend on the artificial intelligence, but putting in all the data and then trying to correlate with your own clinical finding, that can really justify as to whether treatment has to be started and how you have to manage the payment.
But the problem is that the clinical findings themselves are quite noisy. When the noisy means that there's no agreement actually between, even in a given situation, in a given patient, even among the experts, we have 100 experts, they will have 100 different views of the same patient, and that's where actually the artificial intelligence may actually score at some point of time better than human beings, because all the situation where the data is noisy or when the decision making is noisy, I think to reduce that noise, I think AI perhaps may be a little better option. And glaucoma is one such area where there's a lot of inter-individual, inter-expert disagreement, I would say, is quite high in glaucoma. And that's where the AI could perhaps help us. Thank you very much. I think it's a very exciting field. We need to watch it and know more and more about it. And I think we'll go to the next topic. Dr. Amit Horwali is going to tell us about the combined surgery, phaco and trabeculectomy. Dr. Amit, please.
IOP, and then you can release the releasable suture. Closure of the congenital flap is very, very important. What I showed you is an anchoring suture, that's episcleral or the limbal anchoring suture, so that you don't want the bleb to be retracted behind. So pass suture through the episcleral tissue or the limbal tissue, and then do interlocking sutures with the 8-0 bicular suture. This way, if you suture the congenital flap, the posterior bleb retraction is minimized and you get a well tightened. And usually do this on either side of this congenital flap, so you don't have to put a then mattress suture into the center of the congenital flap which has been dissected. Because if this flap is loose, then to avoid retraction you might need to have a mattress suture in the center of the flap also. But by following this dictum, that use an episcleral flap and make it watertight so that you don't have any leakage. And whatever filtration is occurring because of the large posterior congenital dissection you have created, you get a large posterior diffuse bleb. Always remember, never overfill the anterior chamber with viscoelastic, because that will cause iris to be prolapsed. So there should be an adequate AC depth. Air is always, I find air is very helpful, very kind to all of us. Whenever your AC is collapsing, just put air and you close it, and you can get a good control. This is basically another technique of twin site, that is the phaco trap using a Malugin ring. So again, we are glaucoma surgeons, we have to remember that what we experience is small pupil, and we have to be pre-operatively decide how we are going to manage this small pupil. So in this patient, this was a case of complicated cataract with secondary glaucoma and uncontrolled pressures. So I thought she had a complicated cataract also, so I planned for a combined surgery. So follow the dictums which I've already said. Ideally, the conjunctiva and the tenon should be cut in one go, as much as posterior dissection as possible. In this case, after doing the cauterization, I'm going to use a wax sponge. So there are two different variations. Whatever you want, you can use it. And again, when you have made the scleral flap after the phaco, now in this I'm doing the internal ostium with the help of 11 number blade. So this is a wide internal ostium which I'm creating almost about 2 by 1 millimeter. And again, as I told you, if your AC is not too deep, you won't have much of iris prolapse, and you can get a good control. We still have 18 seconds showing. So again, closure, I'm using one apical intermittent suture and 2 releasable suture on either side. So you can titrate the way you want, but initially if you're starting with this surgery, I feel use one apical and 2 intermittent sutures. Be comfortable with whatever you're performing, and then you can slowly shift on to one apical releasable suture. So thank you for your kind attention, and I just had a small appeal that I'm going to contest for the member scientific committee in the coming AIS elections. So require your blessings and supports. Thank you.
Thank you, Amit, for I think excellent videos. I think demonstration of the technique. Any quick questions to Dr. Amit? You always do single site or double site?
I always prefer twin site. I always prefer a twin site because I'm a temporal
Is there any
phaco
difference
surgeon.
in the incision that you make for cataract surgery? Is the same like any other phaco surgery, or because in phaco, you want to have a little larger corneal valve, so that the wound doesn't leak. So
yeah.
is there any difference in these?
So usually what I follow is a 3 planar incision when I'm doing my phacos.
Right.
So I do a temporal phaco 3 planar, usually it is 2.2 and superior trap. If I feel that the leakage is there, if I feel that I might have to give some bleb massage or
you
anything.
don't vary the technique of your incision entry into the anterior chamber in phaco only and phaco plus trap.
It's the same incision is what I follow.
So doesn't that what I'm concerned is that because in phaco you're going a little more into the cornea because you want a good flap there, so you'll cut back with the Cali sponge and you'll remove that part of the cornea.
No, you mean doing the single side technique? Yeah. So
side.
in the single side, if it is a single side phaco trap, I'll advance it more into the anterior chamber, into the cornea, so that I get a good opposition. But the preferred technique is a dual side, twin side technique, because temporal phaco everybody is used to it, and that gives a better control. Only thing is, if you are using more than 2.2 incision, if you are using a 2.8 millimeter or 3.2 for the phaco, then I would advise to put one intermittent suture at the phaco incision site also.
Okay, thank you, Amit. I think we are at the end of the session. Actually, we have consumed our time. So, yeah, quick question. Yes, please.
ECG patients, he's been had a lot of acupuncture glaucoma, and I find that the cornices are very shallow in these patients. So in those situations, would you be able to do a single site? I find because
That's what I told. I always prefer a twin side.
he
Initially in my talk,
prefers
I told
dual
that
side.
whatever technique you are comfortable, go ahead with that. I am comfortable with my temporal phaco, so I do a twin side only.
because I think single site can be done in OAG easily, but for ECG it's
Because the narrow palpebral fissure is very difficult also, yeah.
Okay, thank you very much. I think we had a good discussion on different topics since the time is over. So we'll have to close this session. Thank you all very much to stay, and thank you all the speakers. Chairperson. Yeah, please come for the group photo. Thank you.